arm, hand, wrist cases, stuff like that. I'm not sure who's available on the panel or where to go, but start case I saw a few weeks ago, actually. A 15-year-old male was being tackled, made a 20-yard gain, and then got tackled, landed on by about 5 or 6 other people. Kind of had some pain, shoulder, chest area, and immediate numbness tingling to his left arm. No other symptoms, and was taken off the field right away. Looking at him, he had some asymmetry over the chest. The left side medial clavicle was displaced posteriorly. He had good pulses, no stridor, and he had eaten something on the way to the ER because he was hungry after his football game. So no esophageal compression. It's a little hard to see on this CT scan. I don't have any good x-rays, but what do you guys kind of notice here, left side here versus right side? So it looks like on the left side, the medial clavicle is displaced behind the sternum. Here's the sternoclavicular joint on the right. Here's the left. Not the best CT scan. I've seen an outside hospital and then sent our way. So, posterior sternoclavicular dislocation with some numbness tingling, maybe some brachial plexus compression, but no loss of blood flow or no difficulty breathing, no central compression. How urgent do you treat this? What's the treatment plan? So for us, and Jason, I'm not sure who else is there or how much you want me to talk versus asking people's opinions. But
hey, Kevin, this is, can you hear me?
Yeah, I hear you.
This is Reed Hoyer from Indianapolis.
Hey, Reed.
These ones scare the crap out of me.
Yeah.
I mean, I think that I guess this is a posteriorly dislocated sternoclavicular joint, and I think this is one that probably needs to be treated, not emergently, but in the same hospital stay.
Yeah.
And I guess my initial approach would be an attempted closed reduction, but I'm always nervous about what happens if it's not stable and I have to do something different.
Yeah. So yeah, that's kind of our thoughts too. I think in a kid, and generally kids under 25 or so, the medial clavicle is still a physis, and so you oftentimes will get a physeal separation versus a dislocation, which is not quite as bad because the epiphysis stays intact. It's not quite as big of a piece that goes posteriorly, but it certainly scares the crap out of us too in terms of all the structures right behind the clavicle. So. Our thoughts are get our ducks in a row and then do something to reduce the injury. So we get general surgery involved. I'm not sure what happens at your institution, but generally need somebody who's either general surgery comfortable with a thoracotomy or a thoracic surgery person available, not necessarily just in their office, but in the room in case something happens. They're there to help out, and then try to reduce the injury and then fix it if we need to. So for these, so we took this kid, sort of, got a CT angiogram, make sure there was no other bleeding issues that we could see, no swelling, no compressed hematoma or something. And then we put him on the OR table, and we put a bump in between his shoulder blades and let gravity kind of work, and it sort of popped back into place. But it was still unstable. You could kind of move the clavicle around, just grabbing it and moving it. So then we did an open approach. This is a different patient, but the same idea. And you can see here's with the hole in it, there's medial clavicle, and here's the physis a little bit towards the midline. And then once we're done, this is my patient that we did this on. We could reduce it. We put a couple of drill holes in the metaphysis, and then put a number 5 fiber wire through the epiphysis with a figure of 8 stitch, and then held it together that way. And then we were able to, hopefully the video works, you could really shift that clavicle and it wasn't going to move anymore. So general surgery was there, making sure I didn't mess anything up, although I do a lot of thoracic outlet surgery, so I'm operating in that area all the time and somewhat comfortable with it. So it's a tough one, but worked out well for him. We stayed another 24 hours just to watch and make sure numbness tingling went away, arm was well perfused, eating well, so able to send him home and get this to heal. Let's see. I gotta move on somehow. So that's a tricky one, and I'm not sure in the adult setting. It's more commonly described in kids. In adult settings, it's more of a dislocation, which is more emergent. I think the epiphysis part will actually compress the trachea and the esophagus a bit more. So those are some things that might need to be done emergently in the ER if they come in having some extremis. So I'm going to move on to the next case unless anyone has any questions about this one. Nope. Okay.
Yeah, Kevin, you can go to the next one. I don't know how you topped that one. That was an amazing presentation.
We're going to try. So this is a case I saw a while back. It's a 4.5-year-old male. He was hanging out with his dad doing some yard work, and dad took off while he was in the back of the pickup, and he kind of got catapulted out. Had some pain, a lot of swelling, couldn't move his elbow very well, and was seen at an outside hospital. We had x-rays. Said there's a fracture there, not sure what's going on. And so then he went to see the general orthopedic surgeon in Kentucky and had this x-ray. So if anyone there wants to see, like, what do you guys see on this x-ray with the white arrow sign? You're welcome. So I guess hard for me to hear you guys too, but there's certainly a piece of something, right? There's a piece of bone here, fleck of bone. Something got avulsed, not sure what it is exactly. The rest of the elbow looks pretty well lined up. But to me, the curvature of this piece of bone would fit sort of here. And then that makes me wonder what else is attached to this. You can almost see a soft tissue shadow here too. So he was casted for a couple months because they weren't sure what was going on. Saw a small fracture. He came to our office 4 months later because he couldn't move his elbow, never regained motion, had some pain, elbow looked kind of wonky with the medial prominence. And so he came in to see us, and that's his elbow picture. You can see this is medial where the bump is. Here's lateral, some swelling a little bit, but that's his motion. He had from about 80 to about 30 degrees of motion at the elbow joint. So obviously something's wrong here. What people
I don't know if we ever saw a lateral x-ray.
Yeah, lateral wasn't very helpful.
Okay. But we saw what you were describing, so
yeah,
something's not right.
Yeah. So rule number 3 for me is if something's wrong, something's wrong. So if something's not right, you got to figure out what's wrong. And so,
Kevin, quick question for you: if in that initial presentation situation, I'm afraid that I would have missed this too. When do you think about getting like advanced imaging on these kiddos? Because if you get an MRI of this kid, you're probably gonna have to sedate him, right?
Right. That's the tricky part, right? It's something we'll talk about in a little bit. These are trash lesions where trash, TRASH, the radiographic appearance seemed harmless. So someone described by Jim Castor in Boston, and it's tricky. You see, like in kids' elbows, there's a lot of cartilage and not a lot of bone, and so if you see a tiny avulsion fracture, then you want to do something to figure out what it is, and that's either a good exam to make sure it's not anything big, or an arthrogram or an MRI. And to me, hindsight is pretty easy to see, like, oh, there's something wrong with this elbow. And now looking back at that fleck, it doesn't quite add up. And so I probably would have recommended an MRI early. But you're correct. You have to sedate kids for that. And that's a hard sell sometimes, unless you can, feel comfortable saying, like, there's something wrong with this. And that's kind of things where things are out of proportion. Where you see an elbow like this, where soft tissue swelling, massive soft tissue swelling medially, not so much laterally on this side. And so you have to kind of look outside the bones and see what's going on to really say, like, there's something going on besides a small, tiny fleck of bone going on this elbow. And so that's kind of where, you have to have a little bit of your skepticism, healthy skepticism to go further. For us, it was getting an MRI and seeing what was going on. And it's a little hard to tell, but this is a whole medial condyle that was flipped and rotated 180 degrees out of the joint. and here's the olecranon. Here's sort of lateral capitellum osteotic nucleus here. And a lot of swelling in the elbow joint too. So with that, we went in and we found everything. Here's the ulnar nerve, sort of medial approach to the elbow, ulnar nerve. Here's the piece of cartilage and a small piece of bone that was avulsed out of the joint. Here's the joint here. You can kind of see a olecranon, and that's the place where it came off of on the medial distal humerus. So then we had to build it back together again. So if you look carefully now, you can see this is where the fracture line was. This whole piece with the ulnar nerve moved out of the way now, and then like this medial epicondyle here. Here's the ulnar cubital tunnel. Here's the trochlea. So basically half of the trochlea was avulsed and out of place. And so build it back together again, put a couple of screws in it, and then got it to heal remarkably somehow, with some stiffness persisting beyond that. So this is what we're talking about, the trash lesions. So in kids, you see a lot of these where, medial condyle, transphyseal fractures, OCD lesions, capitellar shear fractures, where sometimes you see a small fleck of bone, but it's a big piece of cartilage, and osteochondral fracture. So you have to have a little bit of skepticism to figure out what's going on with them. And so these are things to watch out in kids' elbows, is that if you see something that, like something out of proportion to your x-rays look out of proportion to your exam shows a huge swollen elbow, nothing, but the x-rays show not much going on, there might be something more happening there. So that's
Hey, Kevin, it's Mike Garcia. I've always found with kids' elbows and looking at these sort of trash lesions and seeing a lot of them, the negative sequelae of them years down the line at the Shriners Hospital, that in the acute case, if a kid's elbow is really swollen, you have to figure out what's wrong, because there's something that's definitely wrong. And a lot of times you'll see, lateral condyle fractures that look completely non-displaced, but this kid's elbow is twice the size of the other one. And so I think clinical exam and having a really high index of suspicion that things are a lot more wrong than you think they are makes a big difference in the acute care of these kids. So big swollen elbows usually dictate a big problem, and you got to figure out what the big problem is, because like you said, most of the time these x-rays appear remarkably benign.
Yeah, that's I totally agree with you that like big swelling equals a big problem. You'll see this in transphyseal injuries too, where it looks like nothing's going on, or maybe a little bit out of alignment, but you'll see big swollen, big bruises, that sort of thing. And that's an indication of child abuse as well. But like there's something bigger going on there that you have to figure out, is it need fixing, or what is it exactly, and then how to treat it from there. So.
When the transfer center calls for the irreducible pediatric elbow dislocation.
Yeah.
That's always someone's been messing with some kids' transphyseal fracture that doesn't really know what they're looking at.
Yeah, I've gotten that call from residents in the ER, like, "Oh, you have a 2-year-old with an elbow dislocation." Nope, not an elbow dislocation. It's definitely a transphyseal fracture. You just don't dislocate your elbow with it.
Yeah. Give them a hug and send them to you.
Yeah.
So that's all you have, Kevin? Nothing more interesting than those?
No, nothing more interesting than that.
No, I'm just kidding with you. I know you have more.
I'm not sure how long you want me to go, too. I know we started a bit late, so you tell me.
Guys, let's have them show one more.
One more? All right.
Okay, one more,
cool.
Kevin.
All right, so this was the playground injury. This kid was going down the slide. His arm got caught in one of the rings in the slide, and he went, and his arm didn't, and he had significant bleeding on site. Was transferred by helicopter from the playground to our emergency room, which is pretty cool for the kids to see. And then showed up in the ER with bone sticking out of the arm like this, but he had a pink perfused hand with slightly delayed capillary refill, and all of his nerves were intact. He was actually remarkably calm, no real swelling because all the bleeding happened outside the skin. He was able to move his fingers totally normally. And so x-rays, very clear type 3 supracondylar Gartland type, and probably a Gustilo Anderson type 3 as well, like a pretty big big injury. But so he was taken pretty urgently to the OR, one, because he had a pink perfused hand, but no palpable radial pulse, and sort of bad open injury. So we took him urgently to the OR, explored him. He had a 6 centimeter gap in his brachial artery, but his median nerve and everything else was intact. So somehow the fracture coming out had ripped through his artery and had to retract. So we used a saphenous vein graft on him, mostly because his arm was so traumatized. I didn't want to take a vein graft from the same arm, which you can do. And then fixed it. So a nice reverse saphenous vein graft, microvascular repair, plus fixation of the humerus. Wasn't too hard to find the arteries because he was already open and explored that way. So he did pretty well, and sort of speaks to the fact that even if you have a complete artery injury, you can have a pink perfused hand. So it kind of depends on the collateral flow around the elbow. This kid's hand looked pretty normal, except for slightly delayed capillary refill. All his nerves were working perfectly fine because they were not compressed. They were just had pulsed his artery, and you can see the median nerve sitting right next to it. Looked pretty happy. So pretty remarkable story for a kid. Anyway, so that's probably enough cases for me, unless you guys have questions or want to do some more.
Any questions for Kevin about that last case? Any questions, anybody? Sometimes questions are asked about when to approach the elbow anteriorly. When should we do that? Should we have a low threshold, or are there certain things that you found in your experience taking care of these bad ones?
Yeah. So
when should we open it? When should we say it's okay?
So for me, like if I can't reduce the fracture, then I open it anteriorly. It's a little bit of tiger country, but when you're a hand surgeon, that's kind of what you're used to doing, right? Going into anterior elbow and finding things. So it's not too hard to find. It's better to me than doing a lateral or medial incision, unless there's a specific ulnar nerve issue immediately, because you can see everything you need to from the anterior approach. And then, for me, if you reduce the fracture and it feels rubbery in between, like there's no fracture ends grating on each other, then there's soft tissue entrapped in there. And if you don't have a good, palpable pulse right after reduction, and it doesn't feel normal in there, or there's some displacement on the fracture on the x-ray, then you probably have to take out the fixation and try again, or explore and fix it that way. I've seen more like 2 to 3 year olds with pulseless supracondylars and entrapped arteries than other age groups. I don't know if it's just the soft tissues are much more robust, harder to tear, and the arteries get trapped faster or easier, or just where the fracture happens a little bit more distal tends to be more likely. That's just my experience over 10 years. I've seen a bunch of 2 to 3 year olds with pulseless supracondylars reduced and not getting any pulses back, or have a good pulse beforehand and then reduce the fracture and lose their pulse afterwards. So for me, if it's not a normal vascular exam after like 15-20 minutes after pinning, normal like palpable pulses or triphasic Doppler signals and good flow, then I'll explore and make sure we're not missing something. Sometimes there's fascia, or there's that supratrochlear branch of the artery tinting or pulling that in.
So. Okay, great. Thanks again for joining us, Kevin.
Sure. Been my pleasure. Thanks again for having me.